Okay, good morning, everybody. I'd just like to start by welcoming you all to the University of Calgary. And I'd like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, as well as the Tsuut'ina First Nation and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta Region 3. Okay, so good morning. No, it's afternoon now, isn't it? Good afternoon. I'm Rob Dearden. I'm a professor of statistics here at the university. I'm cross-appointed in veterinary medicine and mathematics and statistics. Our speaker today is Dr. Caitlin Ward, who's a postdoc, actually in my group. Caitlin is funded by through a distinguished postdoctoral fellowship from the Canadian Statistical Society, Statistical Sciences Institute. Sorry, that's a bit of a mouthful. She has a very impressive CV with lots of good publications and awards, both for teaching and research. And I think I'm allowed to say this. She's actually recently accepted a faculty position at the University of Minnesota, so she'll only be with us for a few more months. But anyway, she's here today to tell us about some of the work she's been doing. Okay, take it away, Caitlin. I think you're still on mute at the moment.
Okay, thank you, Rob. All right, so thank you all for coming. I'm very excited to be talking to you today about some of the popular approaches for epidemic modeling, and this is going to be framed in the context of COVID-19.
And sorry to interrupt, Caitlin, but I just forgot to tell people that they should put their questions in the Q&A, and then we'll answer. You can answer those at the end. Sorry about that.
No problem. All right, so before I get started, I just wanted to make everyone aware I do not have any conflicts of interest to disclose. So a little bit of background here. So epidemics, as we all know, are going to be the result of spread of an infectious pathogen throughout a community, region, or some other type of population. And our mission in the public health field is really to prevent and reduce illness. And the way that we want to do that is through quantitative, evidence-based public health practice and policy. And statistical modeling is going to allow us to do this, to study epidemics, the dynamics of the disease, understand the epidemiological patterns, as well as inform policy about disease control in this quantitative and evidence-based way. I wanted to start by talking a little bit about the types of data that we use for these models. And the data that or the models that I'm going to be talking about rely on data from surveillance efforts. So these surveillance efforts provide us with daily or maybe weekly counts of newly detected infections, hospitalizations, or deaths over time. So think about the Alberta Health COVID dashboard. The types of data that's available there is the type of data that we use to build these models. And the data can be reported at different types of spatial levels. So it might be counts of infections in a city, it could be province level counts, or even country level counts are the types of data that we're looking at. And sometimes we do have more detailed information on our data, not always, but sometimes we have individual level characteristics for all of the infectious individuals, things like age, sex, or location where they live are sometimes available as well. So here's an example of this type of surveillance data from the Alberta first wave of COVID in Alberta. So this is March to May 2020, and we have on each day there is a count, the number of reported infections on that day, and then I just have a smooth 7-day average here. So we have this type of count over time is what we're looking at. The Alberta data actually has a little bit more information with it, that when you can download it, it comes also with age groupings and these health zones in Alberta. And within each of those groups, we have, again, these counts over time. So this is an example of that, a little bit more detailed types of data that we can have. And in fact, the data that you can download actually has a lot more age groups. They have it at a much finer level, but it's a little bit hard to plot. So here I've just grouped it into these approximately 20-year age regions. And I think they also have more detailed spatial information than just these 5 health zones as well. So we have this data, and this data is really going to be the result of a very complex process of individuals going out into the world, maybe wearing a mask, maybe social distancing, maybe not, contacting other people throughout their day-to-day, and potentially contacting infectious people and having a transmission event where the infection is really transmitted. That's what's producing this data, but the data itself isn't really providing us any information about these specific transmission events. We don't know when people were infected, who infected them, who else they've contacted. All we have are these counts over time. So a useful model the things we would like to have from our model, we would like to be able to characterize the disease dynamics. We want to be able to provide forecasts, and we want to use the models to inform public health policy and practice. So there's a bit of a trade-off here, or balancing act, where we need to try to provide information about the disease and the trajectory of the disease, while also accounting for this nature of the available data being that we don't actually have the information on any specific transmission events. And that's where the sort of challenges in these models come in. In terms of COVID modeling, there's been several highly publicized efforts. So one of the most widely cited of these is the Institute for Health Metrics and Evaluation, IHME model. So I think I should be able to pull up a link. Let me know if you can't see that. But they have on their website, they have projections for lots of different countries, and they have deaths predictions. They have predictions about hospital resource use, and lots of other things that they have available. The CDC and the PHAC also have many popular models that they're using to inform their policies as well. And so what I'd like to do is talk about how are these models, there's so many models that are out there, how are they working? I want to give a little bit of background into the benefits and drawbacks of each of the possible approaches one might take, and then just illustrate how they're working as well. So I'm going to talk about 3 sort of broad categories of epidemic models. I have curve fitting, compartmental models, and simulation-based models are the categories that I'll be talking about. So I'll start with curve fitting. So an example of a curve fitting approach was that IHME model at the very beginning of the pandemic. This is the approach that they were using. So to illustrate this, I've pulled here the death data in Alberta from the first wave of the pandemic. So this is March through the end of June of 2020. And you can see here, we have sort of a trend in both the new daily deaths and these cumulative daily deaths. There's some type of trend. And the idea with a curve fitting approach is we want to fit a curve that describes the trend. So the way we do that is we pick some type of function that follows the trend that we see well. Then we can derive the parameters of that function based on the observed data that we have. And what's typically used and what was used often at the beginning of the pandemic was this type of S-shaped curve, and that's used on the cumulative incidence or cumulative mortality. And in these S-shaped curves, we have sort of once the epidemic starts to take off, we see this exponential growth phase, then we have a transitional phase and a plateau phase. And you can see, looking at this curve here of an S-shaped curve versus our cumulative death data in Alberta, it's not an unreasonable function to think about for fitting as a curve fitting approach. So I went ahead and did that. The S-shaped curve that I chose here was a logistic curve. So that has 3 parameters: an asymptote, or the maximum value where the curve is going to sort of tail off towards the end. Then we have the inflection point and the growth rate. So fitting this logistic curve, we're able to describe the trajectory of the cumulative COVID deaths in Alberta. And it does a pretty good job. So maybe at the beginning of the pandemic, it's a little bit overestimating the deaths, but overall, it does fit quite nicely to the data that we see. One thing I wanted to point out, it's a little bit hard to tell here, but we do have a confidence interval around the curve. It's extremely narrow. So because we fit this sort of pre-specified function, this logistic curve, we've decided that this will describe the curve. There's not much variability that we can really allow in that, and it leads us to these really, really narrow confidence intervals, which are certainly too narrow for describing this process. So this is exactly what the IHME model was doing at the very beginning of the pandemic. So before they had expanded to doing many countries, they were actually just using US data, and they had fit these S-shaped curves for each state in the US. And in their model, they had parameters for the maximum growth rate, they had state-specific inflection points, and state-specific growth parameters. So this is called a nonlinear mixed effects model because they have these fixed effects and they have random effects for each state. And using this model, they were able to produce forecasts for new and cumulative deaths for each state. And they were able to do this at the very, very beginning of the pandemic when we didn't have a lot of information about COVID and how it actually was spreading or how it progressed within a host. One clear disadvantage of this type of approach is it can be very sensitive to the functional form that you choose. So using this S-shaped curve on the cumulative deaths or cumulative infections is going to sort of implicitly assume that the population will continue to follow mitigation measures until the epidemic was over. So we started to see deaths decline during this first wave because people had we had a lockdown in place and other mitigation measures. And this S-shaped curve is going to have this asymptote value where we assume that the number of deaths reaches its peak and never continues on. And this is, of course, not what we saw in actuality. So here I've plotted the rest of the year of 2020. In the black, you can see the actual death trajectory compared to what our model would have predicted. So using these curves can be a bit challenging because they're, in terms of forecasting, going to be very sensitive to the functional form that you choose to fit to your data. So just to summarize for curve fitting, so this is a very simple approach. It's easy to implement and update as new data comes in. Another advantage, particularly at the beginning of the pandemic, was that it doesn't rely on disease-specific parameters. And the reason this is nice at the beginning of the pandemic is those are pretty uncertain at that point. So it allows us to do forecasting without knowing too much about the actual disease. Sort of on the flip side of that same coin, because it doesn't rely on those parameters, it doesn't tell us anything about the disease dynamics. It doesn't tell us how transmissible the disease is, for example. Then, as we just saw, it's difficult to use when we have disease resurgence and relies on that accurate functional form to be selected. And another disadvantage, as we saw with those extremely narrow confidence intervals, it's actually going to severely underestimate the uncertainty in the epidemic process because it's just fitting a curve to the trajectory that we see. So it can account for things like super spreading events, for example. All right, so that brings us to the second approach that I'm going to be talking about, compartmental modeling. So after the IHME model scrapped this S-shaped curve approach, they moved to a compartmental model. Another example, the PHAC has some compartmental modeling that they're doing as well. And the general idea with compartmental modeling is that it's infeasible for us to model all of these very complex dynamics of the infectious disease process that I discussed a little bit ago. So in a perfect, maybe a perfect statistical world, we would really have data on everyone's location at all times. We would know who they contact. We would know if they contacted infectious people or not. We would have quite a bit of information about people, and that would help us understand this infectious disease process. Of course, we can't do that for many reasons. We don't have that data available to us. So what we do instead is we average over individuals, and we try to do so in a way that we're capturing the most important disease dynamics. And that's where these compartments come in. So we capture these important dynamics by dividing the host population into compartments. And the original compartmental model is called the SIR model, which is shown here, and it has 3 compartments. So the first compartment is the susceptible individuals. So those are people who are able to contract the disease. They are still susceptible to it. Then we have the infectious individuals, are people who have the disease and can transmit it back to the susceptible individuals. And the last compartment here, the removed compartment, is going to include people who have recovered with immunity, as well as those who have died due to the disease. So we can break up our population into these 3 compartments, and we assume everyone within the same compartment will all have the same dynamics, and we're able to understand the disease a little bit better. So these models are going to be parameterized in terms of the rates of flow between the compartments. So in this simple SIR model, we would have 2 parameters describing the flow from susceptible to infectious and then infectious to removed. And often we call these beta and gamma. So beta is describing how individuals transition from susceptible to infectious. It's called the transmission rate. And gamma is called the removal rate. And it turns out gamma is describing how long people are infectious, such that 1 over gamma is going to be the mean duration that an individual is going to be infectious with the disease. These parameters can be combined to get us at this most important quantity to come out of these models, which is the reproductive number. So the reproductive number, which is called R0, is going to provide the expected number of secondary infections caused by a single infectious individual in the population. So it's the ratio beta over gamma, which we can conceptually think about as how transmissible the disease is. We want to take that and multiply it by how long people are actually transmitting the disease. And that's going to tell us how many people we would expect them to infect. And the reproductive number has this sort of thresholding behavior where if we have a reproductive number that's bigger than 1, that means the epidemic is going to continue to propagate through the population because each infectious individual is infecting at least 1 or more people. So that will make the epidemic continue. And if the reproductive number is less than 1, the epidemic is going to die out. So we have, from this model, we have a very nice interpretation of a parameter about the disease and how transmissible it is. So here's just a table of some reproductive numbers for common diseases from Wikipedia. So you can see here, measles is generally thought to be the most infectious disease. It has a reproductive number 12 or higher, which is huge. Reproductive number means each person with measles is expected to infect 12 other people, which would quickly spread through a population. We have a few different COVID variants here with reproductive numbers. So Omicron, it has a reproductive number around 9.5. Maybe, let's see, the ancestral strain of COVID had a reproductive number closer to 3. And we can calculate this for any disease that we have this type of epidemic data for. Using these compartmental models is how we can estimate this reproductive number. One of the big benefits of these compartmental models is the ability to understand the effectiveness of past interventions. And there's many ways that we can do this. I've done a really simple way here by allowing the transmission to vary over time. So if we're considering our first wave of the pandemic in Alberta, we had a couple key policy changes that occurred. So on March 16th, a couple of weeks after the first case was detected, the province declared a public health state of emergency, which shut down many businesses and restaurants and was effectively locked down at that point. Then later on, at the beginning of April, the use of non-medical masks was recommended. It wasn't mandated at that point, but recommended at that point. So what we can do is allow us to have one transmission level up until March 16th. Then we can have a change in transmission, assume that change continues until April 6th. And then again, we would have a third estimate of our transmission after that point. We can do that and fit that model and then calculate our reproductive number. And that's what I have plotted here on the right. So by doing this, again, this is a little bit of an overly simplistic approach, but I think it illustrates what we're able to learn well. So doing this, we've estimated here that the reproductive number at the very beginning of the pandemic is right around 3. That actually matches up very closely with that table from Wikipedia, which estimated the ancestral strain of COVID to have a reproductive number of 2.9. We see we have a wide interval at that point, a wide credible interval, which is expressing the uncertainty we had about the trajectory of the pandemic at that point, since it had just started. After March 16th, we see a huge drop in the reproductive number. It goes from 3 to around 1.3, 1.4-ish. So it basically is cut in half there. So we have quantitative evidence for the effectiveness of that public health declaration of the state of emergency. It reduced transmission significantly. Again, looking at the change we see on April 6th, after medical masks were recommended, we again see a decrease in the reproductive number, not quite as sharp as the lockdown measures, but we did, looks like we were able to get that reproductive number below 1, which means that the epidemic will not continue to propagate through the population, which is why we see this subsequent decrease in cases starting around maybe mid-April or late April. So the SIR model allows us to quantify how these transmission rates change using these interventions as time points that we can fix. We can also use the SIR model for forecasting. So once we have estimates of our beta and gamma parameters, we can forecast using forward simulation. So at each time point, we can predict transitions between these compartments, which would occur according to our estimated transmission rates. Those are the parameters that we've estimated. So typically this is done by doing maybe 1,000 to 10,000 simulations and then reporting a mean or median and then upper and lower percentiles, which is what I've shown here. A challenge with this is it's going to be a little bit dependent on your assumptions in the model, again, as we saw with the S-shaped curve as well. So here, for this prediction, I've assumed that transmission stays at the same rate it was at the end of June of 2020. So it's assuming that the reproductive number would continue at this value here just below 1. Which would sort of implicitly assume that all of the policies and the behavior of people in the population will remain constant. And if that were the case, we would have predicted that the epidemic trajectory would have sort of a long tail and be over or close to over by maybe the end of the year here. Again, that's not what we saw. We did have some loosening of the restrictions, which causes the cases to go back up. So I've presented here so far just the most simple compartmental model we could do, but we can actually make these quite a bit more complicated in a few different ways. So one way would be to add compartments to the model. So we can, this is an example of a COVID model with added compartments for vaccination and quarantine. They've also added this exposed compartment to capture what we call the latent period. So once someone has contracted the disease, contracted COVID, they might not be able to transmit it to others for a few days. There's sometimes a lag depending on the disease. For COVID, I think we do know that there is a lag, so it makes sense to add this exposed compartment. And here they've also split out that removed compartment to explicitly capture recovery and death. And so you can come up with all different types of compartmental models, but you have to be a little bit careful with the data that you have available to you, because you want these flows of these compartments to be informed by data. Another way you can extend this model is by relaxing some of these restrictive assumptions. So in the standard model, we're assuming that all individuals in the same compartment have the same characteristics, and this actually gives us some restrictive assumptions. So we're assuming we have what's called homogeneous mixing. So everyone in the population is equally likely to contact anyone else in the population. When we're doing this model on the scale of Alberta, that means people in Calgary are equally likely to contact people in Edmonton as they are to contact another person in Calgary, which is, of course, something we know that's not true. We're also assuming that all susceptible individuals are equally susceptible to the disease. So many characteristics of an individual, such as age, would impact the susceptibility and contact process. So we know that older individuals are more susceptible to contracting COVID, and age is also going to impact who you're contacting. You're probably going to contact people closer to your own age as opposed to other age ranges. We'd also like to incorporate some type of spatial heterogeneity. Again, individuals who are living closer together are generally more likely to transmit between each other. So one way we can do this is through age or spatial stratified modeling. So in our regular compartmental model, we can define this infection rate at a given time point to give us this infection over time. So we take beta and we multiply that by the fraction of the population that's infectious at any given time, and we have a time varying infection rate. If we wanted to stratify by age, we could consider, in this case, I've considered K age groups, where in each age group, there'd be an age-specific transmission parameter, and we would weight that by the number of infectious people in that age group. And then we could add that up over all of the age groups to get an overall infection rate from each age group to each other age group. And we can take this same idea to incorporate spatial heterogeneity. Instead of age-specific transmission, we could have area-specific transmission, and then allow transmission within area or between neighboring areas, or we could weight the transmission by how close areas are together. There's lots of extensions that we can do to incorporate these types of heterogeneity. We could take this one step further by using what's called an individual level model. So proposed by our very own Rob Dearden, who introduced me earlier. But in the individual level model, we have our infection rate is further broken down here into 4 pieces. So we have one piece is detailing risk factors associated with the susceptibility of individual I. Then we have this sum over all of the infectious individuals, and we're going to account for the factors associated with the transmissibility of each infectious individual. And we have something here called the infection kernel, which is going to detail shared characteristics between susceptible individual I and infectious individual J. So often this is going to be based on how far apart they are, their separation distance. And finally, we have a Sparks term in this model, which is going to account for otherwise unexplained transmission. So transmission not explained by these susceptibility or transmissibility characteristics. Okay, so to summarize compartmental modeling, some of the advantages of this approach is it's going to give us direct estimates in 95% intervals for these important disease quantities like the reproductive member. We can use this approach to directly assess the impact of previous interventions such as social distancing or mask wearing, and the predictions that we make from these models are actually going to be created according to the disease process as opposed to an arbitrary function. So they're a little bit more realistic. So some of the disadvantages, it can be difficult to find the necessary data, especially if you want to fit these more precise models with lots of compartments or these individual level characteristics. And these models can be a lot more computationally intensive and time consuming, especially when you want to fit the models and update predictions in real time. All right, the last approach I want to talk about is this simulation-based approaches. So simulation-based approaches come by many different names. So you'll see them called agent-based models, Monte Carlo simulations, individual-based simulations, or micro simulations. Those are all referring to basically the same thing. And these simulation-based approaches are going to focus very heavily on individual behavior and transmission. So some examples. So the current IHME model does use a compartmental model, but for their specific part of their model where they're estimating healthcare resources, so how many ICU beds and ventilators will be needed, they use what they call a micro simulation for that. And the PHAC also has some agent-based modeling that they're doing for COVID as well as their compartmental modeling. So in these simulations, we have individuals or what we call agents that are going to interact with the environment, interact with each other according to some specified rules and processes that are determined by the modeler. So the modeler will set up how individuals interact in their simulation. And then what they do is they're going to simulate epidemics in this population, which is behaving according to these rules. Over and over and over again, they do these simulations and then they record the important dynamics that they're interested in. So things like the number of people infected over time, they would record through their simulation. These simulations are going to rely on the parameters that you choose to describe these behavioral rules. So often these are going to be determined from previous literature. These models could also be calibrated by comparing your simulations to observed data to give you better ideas of what the simulation parameters should be. And typically, these are going to be summarized by reporting a mean or median, again, with these upper and lower bounds. So across all of the simulations that are done, what are the typical values and what's the range of values that were observed? So to illustrate this, I have a very simple simulation that we could code up. So we have these 4 sort of rules for our agents in this simulation. So The individuals can be either susceptible, exposed, infectious, or removed. So we're using that compartmental structure to describe the characteristics of the individuals. Then we assume that the individuals have a predetermined social network. So what I have here on this bottom plot on the left is the predetermined social network that I've chosen for my agents. And in this network at this time, we have one person who's infectious and looks like 9 people who are susceptible in our population. So on any given day, each agent is going to have some probability of contacting others in their social network. We call this the contact probability. So we can see here on the second image at the bottom here, our infectious individual, they have 4 connections in their social network. On this day, they happen to have contacted 3 of their 4 connections. So once we have contact, then we might have transmission between an infectious and susceptible individuals according to some transmission probability. So this infectious individual has contacted 3 people, and it turns out in our simulation here, they have transmitted the disease to 2 of those 3 people. So now those 2 people are exposed. For the other people who have contacted each other, there's no possibility of transmission because they're not infectious. We could only have transmission from an infectious person to a susceptible person. So these contact probability and transmission probabilities are going to be the parameters in our simulation. We would want to estimate those using observed data or, again, previous literature. And the benefit of this approach is we can change those parameters to assess the impact of potential interventions. So if we wanted to say what would happen if we had social distancing or a quarantine type of scenario, that would reduce our contact probability. And then we can do simulations under these scenarios with a reduced contact probability. We could also look at things like mask wearing, which would probably reduce our transmission probability. And we can look at various scenarios of how well people are adhering to mask wearing to understand those interventions. We could also add additional rules to our simulation to assess healthcare utilization. We could say each infectious individual then has the probability of being hospitalized. Each hospitalized individual has a probability of needing a ventilator or being in the ICU or dying or so on. So we can make these simulations as complicated as we want. We just have to add in these rules. So one example where I've seen these agent-based models used is for planning purposes for university campuses and how they should plan their return to campus policies. So this is an example from Emory University, where they had this agent-based model, and they had simulated agents that were students as well as staff and faculty. And they included testing, quarantine, and isolation in their simulations. So as people were infected or tested, they might go to quarantine or isolation. They also took into account the testing characteristics. So they were assuming they would give people a PCR test and allowed that sensitivity to vary by day of infection. And then they had this sort of transmission pathways where they're looking at students who are living on campus and off campus, and we have staff and faculty as well, and we look at the transmission between all of these different ways, and they have it plotted out here with the reproductive numbers that they used in their simulation to describe these different transmission pathways. And then what they can do with this simulation is look at how many cases would we expect to have if we did a one-time or no screening, a one-time screening, so everyone comes back to campus and we screen them at that time, and then we let things go. What if we had monthly or weekly screenings? They can see what would happen in those scenarios because they can simulate testing, having people test positive and having them go to quarantine or isolation. And these types of plots are really helpful for decision makers because you can show them exactly here, this is how many cases we would expect at any given time throughout the semester. This is how many total cases we might see for both faculty, staff, and students. And they can weigh those when deciding which approach. They can weigh the costs of each of the testing approaches with maybe the number of isolation rooms they have available for students, and so on. So to summarize the simulation-based approach, these approaches can account for a very complex phenomenon. In these approaches, the modeling is done at the same level as the disease transmission at this individual level, which makes the models very flexible and realistic. And another advantage is these can really aid in decision-making by quantifying the risk of future interventions or potential policies. The disadvantages of the simulation-based approaches are they're only going to be useful if the assumptions and the parameters are realistic. So they do have a lot of assumptions that you have to make about how the agents are going to interact with each other in the simulation. And if those are realistic, you can have really good summaries, but if they're not, it can be a little bit tricky. These models can also become very, very overly complex, which can make them very computationally intensive to run. And even they might also require some specialized software tools. So I know the PHAC model, the agent-based model they're doing is done in a specialized software environment. So it's a little bit less accessible for other people to use. So just to summarize, these three approaches that I've discussed are curve fitting, compartmental modeling, and simulation-based. All of these approaches can be used for forecasting. The compartmental model can also estimate transmission rates and reproductive numbers, as well as the effectiveness of implemented interventions. The simulation-based approaches is going to really focus on individual level behavior and the impact of future policies and interventions. So I lastly just wanted to wrap up with a little bit of talk about future improvement. There's a lot I could say here, but I'll be brief. So the pandemic has really highlighted a need for informative epidemic models. Simultaneously, we've had a lot of challenges making useful models because there's been a lot of important challenges brought to light by COVID. Specifically. So some of these would include the lack of testing availability. So at the beginning of the epidemic, it was really hard to get a test. Even during the most recent wave, at least here, was very hard to get a test, even if you had symptoms. In addition to that, we have a large presence of asymptomatic and undetected transmission with COVID, and that makes it very hard to really estimate how transmission is occurring when we have lots of people who we don't even know who have the disease. Another thing is that's really been brought to light is human behavior and responsiveness and adherence to public health guidelines. So as we saw with some of the approaches I did here, a lot of these models are going to assume people continue to have this responsiveness and adherence until the pandemic is over, but that's not been shown to be the case, especially for this pandemic. And we also have the emergence of new variants, which is really hard to predict and can make these models very challenging for forecasting, especially. All right, so with that, I would like to thank you all for coming, and I'd be happy to answer any questions.
Okay, thanks, Caitlin. Very nice talk.
Thanks.
Okay, so we have 3 questions that I'll read out. Well, you can answer them. I won't read them out all in one go. If anybody wants to put any more in, feel free, because we do have some time. So the first question is, in the SIR model, how exactly would you go about estimating the parameters fitting the model?
Yeah. So I didn't want to go into too much detail on the math on that, but there's a couple different ways you can estimate those parameters. One really common way is to use differential equations. So we're talking about the rates of flow between these compartments, and differential equations is a really natural way to parameterize and fit these types of models. The other way, which is the way that Rob and I typically do things, is the stochastic Bayesian implementation. So we talk about, instead of these rates of flows, we talk about a probability, and we assign this type of data model and likelihood to these compartments and these transitions between the compartments, and we can use a Bayesian approach to estimate those parameters, which is what I had done for that Alberta example.
Okay. So now Ashok has given us a nice long one here that I'll read out. So in slides 19 and 20, you have your time varying transmission parameter beta t, but beyond June, the beta's fast approaching zero. So there's a sort of disease-free equilibrium. So to reinstate or reboot the simulation, how do you vary that beta t? Is there a seasonable variable that could tilt it upwards, or a yes/no intervention, intervention in effect indicator, or compliance, or that sort of thing?
Yeah, I mean, that's something that's really tricky. Looking back at it now, when we know what happened, it's a little bit easier to say, oh, well, we could just say, assume that transmission maybe goes back up to this level that it was at, or maybe it goes a little bit further since they've relaxed the guidelines. And so maybe the reproductive number is somewhere between 1.5 and 2.5. It's probably not going to go all the way back up to 3, but it's kind of something you just have to guess at. What a lot of people do is they'll say maybe 3 or 4 different scenarios for what the reproductive number might be, and then predict out and under those different scenarios. And then you can kind of get a range of worst case scenario, best case scenario, something more realistic in between. But yeah, it's definitely a challenge doing that.
Yeah, I guess there's always also the question of why it's going back up. Right, there's a mechanism behind why it goes back up, and maybe you can try and model that mechanism if you know what it is. But if it's something like a new variant, that's very hard to predict, of course, right, in advance. Okay, and then James has got a nice short question here, but it's a bit of a howler. So has anybody actually used these models to decide on any policy choices, and how did that work out? James, it worked out. You've seen how it worked out. This is the pandemic.
Yeah, not sure I'm qualified to talk about that specifically, but I'd like to think people are using these on some level somewhere. Okay,
I mean, I can add a bit more to that. I mean, yes, they are. So Alberta Health have their own model. PHAC have a bunch of models, Ontario have models, so people are definitely using them to forecast. I think what tied into the last question as well is that generally these models are used to do reasonably short-term forecasts, because so much of the future is really unpredictable, right? Yeah. So I had a question as well. It's actually about the confidence interval in the curve.
Yeah.
So that's actually a confidence interval or a prediction interval?
That's the confidence interval. I almost plotted the prediction interval because it made more sense to me, because it was a little bit wider, but I felt like since it's on the observed data, that it should be the confidence interval.
But how much wider would the prediction interval be? Does it capture the line? Is it that much wider? Or
it would capture the line in most places, except maybe right down here at this part. You can't see it at all, but it is plotted, the prediction interval, in this plot. So you can see it's quite narrow, but
yeah, I have to admit, when you first put that plot up, I thought, Why has my postdoc not put confidence into 14? No.
Yeah, no, they're there. They're there.
All right. Okay. Oh. All right. So Ashok says thanks. Okay. So we are at 12:51. So if there are no more questions, we can all silently thank Caitlin for an excellent talk. If any of you do have further questions, you can send them, well, you can send them directly to Caitlin or to, I don't have the email here. Perhaps it's best to send them directly to Caitlin. You can find Caitlin quite easily via Google. And all right, thanks everybody. Have a good afternoon and good weekend.